I'm going to discuss serious infections, but also how we assess risks and things to think about in prevention. These are my potential conflicts. I have done clinical trial work or consulting with the companies that make the products I will be talking about. So everyone often quotes the Doran paper, and that's shown here. This is, as you know, a result of the work done at the Mayo Clinic, where they actually followed 609 patients for a mean of 12.7 years and looked at the infectious outcomes in this group. 64% had at least one infection, nearly half were hospitalized for infection. Shows you the impact of what happens to this cohort of rheumatoid arthritis over time with regard to infection. And not surprisingly, the things that we associate with infectious risk are shown in the red arrows and highlighted. Chronic morbidities, especially lung disease, severe RA manifestations, and steroids leading the way as a therapeutic risk factor. So we need to obviously understand that infection is big in our patients with inflammatory arthritis. Nearly 25% of all deaths in RA are due to infection. It may be the second leading cause of death, secondary to cardiovascular causes. Pneumonia is the single most common cause of infectious death. Obviously, we have a big issue with prosthetic joint infections in many of our patients. But I think this whole issue is clouded by a lot of confusion, misinformation, misdirection on how these things should be thought of and or managed. And I think it's made worse by the fact that DTC seems to, in the minds of our patients, always highlight infection, infection, infection. And that means we need to be well versed. I'm going to just give you a litany of what I believe to be sort of the facts here that you have to accept or then argue with me at some later point. RA is the strongest risk factor for infection and serious infectious events. That's the severity of an inflammatory load of RA, but also debility. Steroids significantly augment infectious risk. Comorbidities do as well, and don't discount the power of chronic lung disease amongst that group. Age is also a risk factor. SIEs are more common when we use higher doses. That seems to show up most in infliximab. SIEs are more frequent in the first 6 months of use. TNF inhibitors and biologics, therefore, do cause a small but significant risk of SIE. But again, it's sort of overshadowed by the factors I've mentioned thus far. In RCTs, it's a non-significant doubling, which I'll show you in the next slide. In observational data, it's sometimes up, it's sometimes not up. But what is clear is that when you add a biologic onto these other risk factors, it becomes additive and therefore is a bad player. So you can see here's the data from the currently or recently approved biologics. I threw tofacitinib in the bottom. And you can see that for the most part, there's a doubling over the placebo rate when you use the active comparator, except for but a few drugs, and that includes Adalimumab and etanercept. But for the most part, it's a doubling. But those are non-significant changes. In fact, if you look at it when you report it by event rate in the next slide, you can see that in the drug development experience for etanercept, infliximab, adalimumab, the placebo and TNF antagonist rates for SIEs are 3 to 4 per 100 patient years. And that falls within the range that historically is quoted of 3 to 9 per 100 patient years. And 9, we know, comes from the Doran group, where they had 9.7 per 100 patient years infections in the Mayo Clinic. Other studies, older studies, pre-biologic year, are in that 3 to 4 range. So here's where this number, this range is. You can see the 3 to 9, and here's some recently, or over the last 10 years, approved drugs, and where they fall in their drug development experience. Again, this is patients with only severe rheumatoid arthritis, comorbidities excluded, steroids are limited, and those are the rates that you get. Again, it falls within the expectation of what you would see in someone with rheumatoid arthritis, especially severe enough to get into one of these trials. Now, what about in the real world experience? Here's a listing of 6 large data sets, if you will. The German registry, Rabbit, the Japanese registry, Medicare, United Healthcare, is Jeff Curtis's registry, Artis is the Swedish registry, Schneeweiss is a Medicare registry, and BSRBR is the British registry. And what do you see? The rate for SIEs in this very large data set is within that range of 3 to 9 per 100 patient years. But when they compared that TNF inhibitor rate to a comparator group that was only taking methotrexate or DMARDs, you can see in some of these studies, it's a doubling of risk. The adjusted hazard ratio or rate ratios are around 2. But in other studies, it wasn't. It was basically 1 and not different. And this is sort of the story behind infection. Sometimes it's up, sometimes it's not. And the difference really, I believe, is the host. There are host differences that are in play, and that's what you need to consider if one is trying to reduce the risk of infection in at least RA. This is the data from the rabbit registry, and I think it's going to become very important. You'll see more of it. But what is shown as you go from left to right is increasing use of steroids from low dose to higher dose, 15 milligrams or above. And it compares in the first row the rate of SIEs in those receiving DMARDs and those receiving a TNF inhibitor. And then in the rows that go behind it, you're adding on risk factors that are shown, or comorbidities that are shown on the right. Age, chronic lung disease, chronic renal disease, a number of high failures, and prior serious infectious events. And you can see that for the most part, there's not much difference in the first row between TNF and DMARD. It doesn't seem like it adds very much, and when it does, it's when we're on high doses of steroids. But as you go back, if you're on high doses of steroids, then you have 2 or 3 risk factors. Now the addition of a TNF inhibitor seems to be, uh-oh, maybe I shouldn't have done that. So again, it's going to ultimately fall into patient selection when trying to avoid infections. The problem with steroids is that we have a lot of people taking them. In private practice, it's as little as 30%. In clinical trials, it's as high as 60%. And it's clear that when you add in steroids, even in low doses, it improves the clinical outcomes. It improves even the X-ray outcomes. But it's very clear from multiple trials that low-dose steroids will increase the rate of non-serious infectious events. The #1 side effect seen in almost all clinical trials, colds, URIs, flu, nonsense little things, but for which no one had to stop the trial or suspend their therapy in clinical trials, and that's with over almost, 12, 15,000 patients, but yet that's the common practice out there. I don't know why, but steroids clearly increase the rate of non-serious infectious events. SIEs, there's multiple data sets and multiple diseases showing that, and even opportunistic infections. So they are risk factors, they're an additive risk factor, and even worse, they tend to blunt and obscure the signs and symptoms of serious infection, which makes it even more worrisome. We know that it's not necessarily the drugs, but it may very well be just the disease activity that drives infectious risk. On the right, you're seeing a plot of the British Biologics Registry comparing DMARD use to etanercept use, showing you that it really doesn't matter, but they both go up according to the DAS score. So in the BSRBR, for every 1 point increase in your DAS score, you have a 17% increase in SIE rates. In the Corona Registry, for every 0.6 increase in DAS score, you have a 4% increase in SIE. Again, activity and RA and inflammation drives infectious risk. Do these drugs cause increase in hospitalizations? And here's 5 data sets basically showing all the same thing with the exception of 1, showing a slight elevation. This is, again, the United Healthcare database, showing that even though we have very large numbers who are on TNF inhibitors who are compared to those just on methotrexate, there's not a higher rate of either hospitalization for those causes or hospitalization for COPD. In randomized clinical trials, they've actually looked at what happens when you give a TNF inhibitor to patients who have a comorbidity or 2. And these are not severe comorbidities, but to be enrolled in these 3 trials with adalimumab, infliximab, and etanercept, you had to have a comorbidity, you had to have active disease, you had to be on a background DMARD, and then you got either a placebo or a TNF inhibitor. And across the board, the TNF inhibitor seemed to make no difference with regard to the outcomes, except for the infliximab trial when they used the higher dose of infliximab, 10 milligrams per kilogram, where here you have a 5% rate, which is almost 4 times the rate of SIEs. By the way, the same high dose group is where all the TB cases came from in this clinical trial as well. So again, it's probably the high dose, but you can use a TNF inhibitor or a biologic for that matter in patients who have a comorbidity. It's otherwise not too severe. Now, it's just not the TNF inhibitor and activity. There are other drugs that we use. And again, to keep it in perspective, I have 2 very large Canadian trials. These are really well-done trials, one by Sasha Bernatsky and Lekale over here, over 20,000 patients. You can see in both trials, the bad players are cytotoxic drugs. You know, I mean, very high rates of, 27 per 100 patient years if you're on Cytoxan on the right here. That's incredible. Prednisone's always a bad player. And other bad drugs are sort of in there. What's not in there are the usual DMARDs that you use, methotrexate, leflunomide, sulfasalazine, plaquenil. I didn't show you all of them. They tend to do very well and don't seem to increase the rate. What they showed in the Bernatsky trial is that the rate was greater when you actually add steroids to DMARDs, especially the bad DMARDs like Cytoxan. And on the right, what you see is that the interesting thing was that the DMARDs actually were shown to reduce the risk of mild infections. They actually looked at mild infections. That would be the URI, NSIE kind of thing, and almost reduced it for serious infections where it was 0.92 and the p-value was 0.052 and it wasn't quite significant, but it was close. I've made the point that it's disease activity, and what about if you control disease activity? Would you not lessen the risk of infection? I don't have any good evidence of that from any trial, and the evidence I do have is too poor to even show you. This is probably the closest I'll come to showing you that controlling the disease will actually lessen the risk. And I think in any one patient, they have a dynamic risk based on their disease, host factors, what drugs they're taking, and it's a shifting risk that may go up a little, may go down a little bit, and maybe controlling activity may lessen it, but there are other factors that are driving it back up. So the best you can do is that there's no increase as opposed to a reduced risk. But again, this is the best I can show you about reducing risk. Just an example of one infection. This is the BSRBR published in 2011, looking at septic arthritis. You can see that they had more cases of septic arthritis in their 11,000 TNF patients compared to their 3,000 DMARD-treated patients. And this is the DMARD risk on the red on the bottom, and this is the 3 TNF inhibitors, which were not significantly different from each other. The hazard ratio for a septic arthritis on a biologic here was 2.3. The risk was greatest early, as shown in that bottom graph, and tails off over time. That's depletion of susceptibles, and especially in those who had a prior joint replacement. So a lot of these people, there's a risk factor that makes you more susceptible, whether it was a prior serious infection event. In these people, it was prior joint infection. Interestingly, in this study, there was not a higher rate of post-op infections when they were taking a TNF inhibitor. So again, we'll talk about that, I think, actually in the next slide. So everybody wants to know about surgery and what do I do with my TNF inhibitors and whatnot. This is a very interesting study that was presented last year's ACR. 50,000 orthopedic surgeries done over 8 years and 37,000 patients. You can see when they divided up into those with degenerative disease, the rate is relatively low, 0.8%, but it's higher with inflammatory disease. Inflammatory disease like RA on a DMARD or on a biologic, it's even higher. So the odds ratio does go up significantly across the board. What's important here is that the overall risk, if you're on a TNF inhibitor, hence you have inflammatory arthritis, is 2.6. That's close to what you get with inflammatory arthritis alone. But what's important here is that if the risk goes up tenfold, if the surgery was done within one dose interval of the drug being given. So if it was given within the first week of etanercept, let's say, there's a tenfold risk, which says that you probably should wait until you do surgery. So they recommended surgery should be delayed for at least one dosing interval after the use of a TNF inhibitor. So here's a composite of many different trials where surgical site infections, the relative risk or the odds ratios are again about 5-fold higher. The risk seems to be greatest after the administration of the drug and when the drug is washed out. If you have the patient off of the drug way beyond the washout period, more than 3 weeks for etanercept, more than 10 weeks for adalimumab, then they're going to get inflammation, and inflammation is going to drive risk. So the recommendation is don't do surgery at peak drug levels right after you gave the drug. Number 2, don't do surgery at the washout or after they've been off the drug for a really long time. Suspend the TNF inhibitor for at least one dosing interval or 4 weeks. And you can see here that might be 1 week or more for etanercept, 2 to 4 for adalimumab, and infliximab, even as much as 4 to 8. So again, if you're going to overall assess the risk, you have to know the risk factors, and I think we've spelled that out pretty clearly. It's age, it's disease activity, it's comorbidities, especially chronic lung disease, it's joint surgery and any major surgery where you're opening up the skin, your #1 barrier against infection, and basically introducing a lot of pathogens there. Steroids, cytotoxics especially, combinations of steroids plus other drugs, and then biologics play some role, but again, it's an additive role in someone who's already complex. High doses, prior SIEs, data I didn't show you is if you had a serious pneumonia, one that caused hospitalization in the past, before these drugs or even when you're on these drugs, you're more likely to get it again, much more likely to get it again, and the second time around you're more likely to die. That's probably true for all SIEs, whether it's septic arthritis or pneumonia, etc. So to screen, there are a number of things we can do. We do lab tests all the time, looking at white counts and looking for neutropenia, a major risk factor. But do hepatitis screening, doing IGRAs and PPDs, and then monitoring along the line. I'll hit on a few of these. So TB risk, this is a slide I think that comes from Kevin, the next speaker, Kevin Winthrop, showing you that basically host factors, where you're born, what your exposure risk, and the drugs play some role, steroids, TNF inhibitors, et cetera. In a low risk, non-endemic area like Sweden, the population risk is low. We'll call that 1. If you're on a TNF inhibitor, if you're not on a TNF inhibitor but you have RA, it may double. If you're on a TNF inhibitor and you have RA, it may go up 9-fold. Now then compare that to what I call TB land, and pardon me, Korea, but there's a lot of places in this world where there's a lot of TB. And the rates are not what they are in Sweden, United States, Canada, and Great Britain, where the rates are like 3 or 4 or 6 per 100,000 patient years. They're like 90 to 400, okay? So that's what I call endemic and high risk. And you can see that here the population risk is 1, the RA risk is not 2, but it's 9, and an RA on a TNF inhibitor is now 30. Now look at the numbers, and this tells you why you actually need to worry about people who are born in a place where TB is endemic. Here, it's 6 per 100,000 patient years. If you're on a TNF inhibitor, it goes up to 9. If you're on a if your RA, it goes up to 9 or 10. If you're RA and you're on a TNF inhibitor, it goes up to 90 per 100,000 patient years. Still a pretty low risk, but compare that to the endemic area where it starts out at 300, goes to 2,700 just for having RA, and now goes to 9,000 per 100,000 patient years. That's why foreign-born individuals we have to worry about when we're using these drugs. This is the data that comes from the early days of D2E7 when they were developing this drug, which is now known as Adalimumab. In their phase 1 trials where they're using very high doses, they found a large number of TB cases. In their phase 2 trials, they started lowering the dose. They still found TB cases, but they were not doing any screening. This is when they showed that when they did screening and they used more normal doses, that they went to no cases of TB. What's been shown over and over in a number of different trials is that by doing TB or PPD screening or IGRAs, there's at least an 85% reduction in TB risk, which is why you do it. We need to remember that, and this also comes from Kevin Winthrop, is that although TB is a big player, probably the bigger player, one that often goes under-recognized, is non-tuberculous mycobacterial infections. In 30,000 new starts in the western United States up to 2007, this is the population rate, this is the number of cases they had of TB, this is the number of cases of non-tuberculous mycobacterial infection. You need to worry about these because these can be indolent, hard to diagnose. They have cough and fever that won't go away, and they may be extrapulmonary in their manifestations, maybe more common in men. But the idea is you have to have a high index of suspicion. What we know from the product labels is that everybody on a TNF inhibitor should be tested for TB. But also, if you're on abatacept or tocilizumab, leflunomide, and tofacitinib, this is all in the package label. I bolded TNF inhibitors because there's a clear-cut reason as to why that's the case, right? But the other ones, they're in the package label largely because, not because there's been a lot of events, but it's because the trial design that was employed to get that drug approved. Biologically, there really isn't a lot of reason for risk with these drugs, but that's the convention that's in the package label. It's not required for methotrexate, anakinra, and rituximab. Now, you can do it in all these people, but I'm not sure you need to. Drug Safety Quarterly is a publication put out by the American College of Rheumatology. I'm the editor along with Kevin, with Catherine Dow. And we asked Kevin Winthrop and Richard Chasen from Hopkins to help us with some guidance on screening. And this is the statements that came from a nice piece that was done 3 years ago. Number 1, everyone should be screened for LTBI. Number 2, when do you do an IRG, an interferon gamma releasing assay like quantiferon, when it's available and when there's a history of BCG vaccination. Number 3, BCG vaccinated patients should be tested for LTBI. Remember, they come from a place where it's TB land, right? So they're likely to have TB if they have a positive result. And you can do the IGRA to figure out if it is due to actual latent tuberculosis infection or due to the PPD. Either PPD or IGRA positivity is evidence of infection. A two-step TST is only recommended in healthcare workers. A chest X-ray may be used for screening, but it is really only helpful in diagnosing active TB, not necessarily telling you that you have LTBI. PPD should be done and repeated or done periodically. Again, the package insert for all the biologics where it's requested says that it should be done and repeated. They don't tell you when or why and whatnot. Basically, my view is it should be done twice. You may find something interesting the second time around. I'll show you why. And then only when risk changes. They have exposure, new travel, etc. 8, a documented history of an adequately treated case of LTBI or an adequately treated case of active TB can safely receive TNF inhibitors going forward without the need for further testing. The incidence of reinfection on a TNF inhibitor is directly related to the exposure. So if you're not in an endemic area or a high-risk situation, your risk is basically 0. If you are, you could get infected again. Number 9, and very, very important, an LTBI, what the package insert says is that preventative anti-tuberculous therapy must be initiated before giving a TNF inhibitor. That doesn't say 2 weeks, it doesn't say 2 months, it doesn't say a 6-month course, it says before, and that means I give you INH in the mouth and I put the IV in your arm and you get infliximab 3 minutes later. That meets the letter of the law, and believe me, the CDC and the FDA carefully considered that when making that statement. 10, guidelines do not recommend screening for methotrexate and other DMARDs. So the need for repeat testing comes from, we did a study at my center. I like the data as it's presented by Corey and colleagues from UCLA, where they have an endemic group. They had 400 patients going on a TNF inhibitor from LA County Hospital. You can see that they had 100 that were positive. I think that's a high rate of positivity, 300 that were not. And when they were screened yearly, you can see over time they found 30 cases amongst the 300, or about a 10% rate of positive PPD in people who were once PPD negative. Now, in my opinion, that generally means, what we found in our study, is that means you were probably anergic at the outset, but you don't know that to be sure. And certainly when you treat them and their inflammation gets better, then you can discover what happens. But here, what they did, what was very interesting, is they cultured everybody, and 7 out of the 30 were culture positive. So not only do you find that they have LTBI, you have to do a chest X-ray, you have to ask about signs and symptoms, but you really should culture to make sure that don't have active infection, because obviously treatments would be very, very different. This is a reason to do it at least twice, and then when risk changes. Again, we worry a lot about, if you're from an endemic area like the middle United States or here or on the West Coast, where histo and coxi are significantly important risk factors for patients on biologics, and especially TNF inhibitors. The problem is there is no screening test. It's all about signs and symptoms. And you have to have a high index of suspicion with these people. One of the problems here is that these are rare events. They have unusual presentations, not the usual, just like TB. They're extrapulmonary, and there's often delays in diagnosis. When the FDA and others have reviewed these cases, they found a high percentage of them that led to death, a high percentage of them that died without any investigation or treatment. And that's why when the FDA came up with a warning about this, they said clinicians should consider initiating empiric antifungal therapy when evaluating at-risk individuals with an undiagnosed systemic illness or an FUO. So give them the anti-tuberculosis therapy or fungal therapy, and then work them up and find out if in fact they have that. You can see this is one such report from Medline looking at 281 cases from the MedWatch experience. You can see 30% were histo, 32% died. That's ugly. Vaccinations, everybody should be vaccinating in a population-based look at things that would clearly reduce the risk. You have to know that RA patients have a suboptimal response, that nonetheless, good humoral responses can be seen when you're on drugs like methotrexate, prednisone, a TNF inhibitor, abatacept, tofacitinib, and even tocilizumab. The package insert says that because of the possibility of impaired responses with rituximab, IVIG, and tocilizumab, you probably should vaccinate patients prior to using those biologics. The PDR says no, don't use live vaccines, and that's because there's a remote risk of dissemination and activation of that infection. What we've seen is that it generally doesn't happen. It seems to happen mainly in kids who are on transplant and immunosuppressives. But the line that comes from the CDC guidance document on Zoster basically says that you could stop the biologic, be off of it for 4 weeks, give the vaccine, and then restart 2 weeks later is basically the guidance. Influenza is more common in RA, and complications of influenza are also more common in RA, and that's shown in this slide. I don't have time to go over with. We're not very good at vaccinating. You can do better. I know you can. The vaccines that you have to worry about as far as live vaccine are shown on the right. That includes nasal influenza, PO typhoid, yellow fever, Varivax, Zostavax, MMR, BCG given intravesicularly, polio, smallpox, anthrax, and rotavirus in newborns. Well, several hotlines have been written by the ACR. This is the one that Artie and I wrote in 2011. He has a follow-up that came out last year. Shingles occurs in 1/3 of the population. Zostavax reduces the rate of shingles by 51%. It reduces the rate of postherpetic neuralgia by 67%. On the top right, you can see the age-related risk for Zoster as it goes up, and the current indication is for age over 40, but if you have our patients, it's for age over 60. I don't know that there's that big enough difference that we shouldn't be covering people at age 50. You can use the Zoster vaccine in patients who are on methotrexate and DMARDs like azathioprine and even low-dose prednisone. It is not indicated for treatment of acute Zoster infection or postherpetic neuralgia. You should avoid it when you're taking biologics. And again, the guidelines that they came up with was you give 2 weeks before and 4 weeks after anticipated immunosuppression, that meaning biologics. Are Zoster infections increased? I mean, if you look at the weight of the evidence, it seems to be so. If you go look at the slide before, excuse me, I'll go back. Down here, this is the OA rate of 10 per 1,000 patient years. RA rate is 15 overall. You can see up here in Wegener's, it's 43. In these large studies with large numbers of patients, the rates range from 7 to as high as 13. It's kind of within that OA, RA rate, and it's generally higher than what you see in psoriasis and whatnot. These first 5 studies basically say there is a higher rate, and there's a 6th study, which I don't have on here, that came out from the BSRBR recently, saying it's also higher on TNF inhibitors. Kevin and his studies show that it's much higher in RA compared to psoriasis and other conditions, but nonetheless, it didn't matter whether you're on a TNF inhibitor or a DMARD, RA patients have a higher rate. So our patients probably have a slightly higher rate of Zoster, so knowing what to do and how to handle that is very important. This is guidance that comes from Lenny, who's looked at this issue and studied this about how to handle hepatitis B. Hepatitis C doesn't seem to be an issue, okay? There's really no cases that I can tell. Maybe one case I can find is someone getting worse with hepatitis C on receiving a TNF inhibitor. Other biologics have not been studied. But with hepatitis B, there's some clear-cut guidance. Everybody should be screened for Hep B and Hep C, looking especially at core antibody positivity. If you have active infection, if you are B surface antigen positive, don't go there. Don't use a biologic. Horrible things have been seen with rituximab and TNF inhibitors in kids and in adults, and refer them to hepatology. If you have resolved infection, meaning you're B surface antigen negative, your enzymes are normal, and your core antibody, however, is positive, hepatitis surface antibody to me doesn't count here, not important because they may or may not have been vaccinated. You can use a TNF inhibitor, but use it with caution. The bottom line is what's shown there, that you should use caution in those with the most intense forms of inflammation and therapy. Even if you're just core antibody positive, you could still reactivate in those situations. So you can go ahead and treat those people, but if you have to use it, you have to use also antiviral therapy. 2 minutes left. What about immunoglobulins and rituximab? A lot has been talked about here. It seems to be confusing. You know, the package, the drug development experience was that these drugs actually would certainly lower B cell counts, but immunoglobulins stayed the same for the most part. Now, this is a follow-up many years later. This is 3,000 patients followed a mean of 9 years and taking up to 17 courses of rituximab. And they looked at what happened to immunoglobulin levels and whether they were predictive or not. You can see that IgM levels didn't seem to matter very much, and the infection rate was very low, around 3 to 4 per 100 patient years. And by the way, 20% of patients were found to have low IgM levels at some point in their history. However, only 3.5% were found to have low IgG levels. And were they predictive or not? Well, if you've never had a low IgG, you certainly had a very low rate. But the patients who developed low IgG after the use of rituximab and those that had it before seem to have a much higher rate. So this group is somehow different as far as their phenotype and their clinical characteristics. We know they had more DMARDs, they were more likely to be CCV positive, they were a little bit older, but it's hard to figure out why they had a higher rate. So when you look at this, the question is, do you do it? No, I don't do them because I don't know what I'm going to do with the results when I see it. Because A, this is a low frequency event, and it has very little predictive value. But there are some of us who do them and want to react to them, but there's no clear guidance at this point on whether you should react to that. Who should not get a TNF inhibitor? 1, if you have active hepatitis with B surface antigen positivity. 2, if you had a non-tuberculous mycobacterial infection because you never fully eradicate that infection. 3, if you had invasive fungal infection. I don't mean oral thrush, I mean blastomycosis or candida going down the GI tract. 4, intravesicular BCG. These people should not receive a TNF inhibitor. By the way, there's an asterisk in the first 3, and what does that mean? If absolutely positively necessary, you can actually treat those situations with a TNF inhibitor, but you have to provide background antimicrobial prophylaxis. You know, antifungal, viral therapy, et cetera. So these have been used in over 4 million people. We know a lot about this. I think screening, selection, vaccination. I think it would be nice to know who not to give these drugs to. It's unclear that if you control the disease, its comorbidities, steroid, whether or not any of that would lead to better rates. That data really hasn't been out there. What I think is we're going to see at this upcoming EULAR and next ACR is data that comes from Rabbit and the German registry, where they've been able to show, using those factors I showed you earlier, that if you're age greater than 60, you have lung disease, renal disease, prior DMARD failures, prior SIE events, they can predict what your SIE rate will be. And they show in this model, these bars that are basically lining up and equaling, the red being equal to green, is the observed and the expected using this model. So I think that they're going to have a website. You can plug in the numbers. You can find out whether your rate is 6% or 12% or 22% based on the characteristics they'll pose to you. You should take an approach that they use in infection control, and that's, you know, these features, look at neutropenia, worrying about joint replacements, hand hygiene, respiratory hygiene, cough etiquette, and whatnot. Again, your clinic should be sort of a bastion of information about infection and how to educate patients on how to avoid that. With that, I'll stop there. Thank you very much.